Hello everyone, welcome to our channel Medi Mantra. In today's episode, we'll be talking about shoulder dystocia. So, friends, shoulder dystocia is an obstetric emergency. The incidence is 0.2 to 2%. So, it is very obvious that every obstetrician should be well versed in how to conduct the delivery for shoulder dystocia. Now, why actually shoulder dystocia occurs? Shoulder dystocia occurs when the diameter of the shoulder is more than the anteroposterior diameter of the pelvis. So, in that case, the anterior shoulder will get impacted behind the pubic symphysis and so it will not be delivered. So, after the head delivers, if there is a difference or time lag of more than 60 seconds, and still the shoulders are not getting delivered, then you define it as shoulder dystocia. There can be antenatal risk factors, there can be intrapartum risk factors. Antenatal risk factors can be women who had previous history of shoulder dystocia, women with gestational diabetes mellitus, women who are morbidly obese, with previous history of unexplained stillbirth, or in women who had sudden IUFD, these women may be underlying diabetic. The intrapartum risk factors can be prolonged first and second stage of labor, women who has undergone augmentation of labor or undue induction of labor, or in women in whom assisted vaginal delivery or instrumental delivery has been tried. So, the diagnosis of shoulder dystocia is made by the following signs. When there is failure of the shoulder to descend beyond the pubic symphysis, when there is failure of the fetal head to restitute after the fetal head has been delivered, when there is turtle sign. The turtle sign is that the fetal head will come out and it will go in repeatedly. It comes out with each contraction and it goes back when the uterus is relaxed. And the most important is the duration after the head has been delivered. If there is more than 60 seconds or 1 minute and the shoulder is not being delivered, then you define it as shoulder dystocia. So once you have diagnosed shoulder dystocia, you have to call for help. It is very important that the senior obstetrician on call and the senior pediatrician or neonatologist should be on the floor. At the same time, you give a call to the nursing staff and the OT technician and the anesthetist. This is because you might have to land up in operative deliveries as well. At the same time, it is very important that you counsel the patient and their attendant in a supportive manner, and maternal and fetal risks have to be explained simultaneously to the patient and their attendants when the maneuvers are being done, because there are possibilities of being landing up into operational delivery. So the first maneuver which we do is Mack-Roberts maneuver. In Mack-Roberts maneuver, you ask the lady to hyperflex and hyperabduct the thigh upon the maternal abdomen. When abduction and hyperflexion is being done, then it will lead to increase in the anteroposterior diameter of the outlet. This is because there will be flattening of the sacrum and the pubic symphysis will come anteriorly, thereby leading to increase of 2 cm of the anteroposterior diameter at the outlet. This will help in dislodging the anterior shoulder and thereby facilitate in delivery. At the same time, when hyperflexion or Mack-Roberts maneuver is being done, you have to ask the woman to avoid bearing down and the fetal heart rate has to be auscultated. Episiotomy has to be liberalized at that moment. Somebody may ask you in the exam why episiotomy has to be liberalized. Always remember, the defect is in the bony pelvis. So liberalization of the episiotomy won't facilitate in delivery of the fetus, but this is given because you have to insert your hand for a lot of maneuvers. So it will help in facilitation of entry of your hand or the obstetrician's hand. So when Mack-Roberts maneuver is being done, you ask your assistant to give suprapubic pressure. So suprapubic pressure has to be given in such a direction so that there is adduction of the shoulder. it will help in decreasing the shoulder diameter. So the suprapubic pressure has to be given directed towards the fetal chest. So from the direction in which the fetal occiput is there, from that direction the suprapubic pressure has to be given. This is called Rubin's 1 maneuver. Always remember, never give any pressure in the fundus. Fundal pressure has to be avoided. This is because fundal pressure will lead to more impaction of the anterior shoulder upon the pubic symphysis. So with this Mac-Roberts maneuver and Rubin's 1 maneuver, 90% of the shoulder dystocias deliver. If the baby does not deliver in this case, then rotational maneuvers have to be done. In rotational maneuver, the first maneuver which we do is Wood's corkscrew maneuver. In Wood's corkscrew maneuver, insert 2 fingers of your right hand in the vagina towards the anterior shoulder. So what we did is, we inserted 2 fingers of our right hand towards the posterior aspect of the anterior shoulder and 2 fingers towards the anterior aspect of the posterior shoulder. So with a corkscrew maneuver, we will rotate the baby such that the anterior posterior shoulder comes towards the oblique plane. If the anterior shoulder gets dislodged, then it will get delivered. If it does not get dislodged, then we will rotate it by 180 degree such that the anterior shoulder will become posterior and it will come towards the sacral hollow. And so the anterior shoulder which was above the pubic symphysis will come down, and the posterior shoulder which was already below will come below the pubic symphysis and will get delivered. So this is Wood's corkscrew maneuver. When the Wood's corkscrew maneuver fails, then you have to do extraction of the posterior shoulder. This maneuver is called Swartz-Barnum-Jacquemeier's maneuver. In that case, you insert 2 fingers of your right hand towards the posterior aspect of the pelvis, go to the posterior aspect of the posterior shoulder and feel the axilla, then reach the cubital fossa and then try to catch hold of the fetal forearm. So you go to the posterior aspect of the posterior shoulder, feel the axilla, go to the cubical fossa, push it so that the arm flexes, catch hold of the forearm, and then you swipe the arm across the chest to deliver the posterior arm. Once the posterior arm has been delivered, then the shoulder diameter decreases and the anterior shoulder will get disimpacted and it will get delivered. When all these maneuvers have failed, then you ask the lady to be on all 4. So when the lady is on all 4, this is called Gaskin's all 4 maneuver. In this position, the woman lies upright on the hands and the knees as shown in this picture, and so this will facilitate in increase of the anteroposterior diameter. The mechanism is not well known and the baby might get delivered. The Gaskin's maneuver has failed. In that case, we will shift the patient to the operation theatre. The senior anesthetist has to come, give general anesthesia and uterine relaxants, and now we will do the Zavanelli's procedure. In Zavanelli's procedure, we will push the fetus back into the uterus and we conduct a hysterotomy or cesarean section and deliver the fetus. In certain conditions, when there is fetal congenital malformations or when the fetus has already died, so we will not do a cesarean section in those conditions. In those conditions, we will go for destructive operations. Destructive operations can be in the form of clidotomy, where we cut the clavicle to decrease the diameter of the shoulder, or in certain countries of Africa where it was historical that pubic symphysis used to be cut, so symphysiotomy also used to be done. So for more informative videos, subscribe our channel Medi Mantra.